All right, let's jump straight into this explainer on step 2 CK pharmacology. Whenever we're starting a patient on a chronic medication, we have to ask a few crucial questions. What exact problem are we treating? Which organ actually clears this drug? And what baseline labs do we need to check to avoid any life-threatening toxicities down the line? This is especially huge for older adults and patients with chronic kidney disease, where reducing polypharmacy and double-checking renal dosing isn't just a good idea, it's absolutely mandatory.
Here is our roadmap for today. We're going to cover diabetes medication management, hypertension comorbidity logic, heart failure and diuretics, statin therapy and myopathy, osteoporosis and bone protection, and finally, high-yield drug toxicities.
Starting off with Section 1, diabetes medication management and clinical branching logic.
So we all know metformin is the go-to first-line therapy for type 2 diabetes. But here's the catch. Because it's entirely cleared by the kidneys, it is strictly contraindicated if your patient has severe chronic kidney disease, congestive heart failure, or liver disease, and if they're coming in with an acute illness, sepsis, or they're about to have surgery, you have to stop the metformin. If you don't, the drug accumulates and you're looking at a severe risk of lactic acidosis. As for the alternatives, keep in mind that sulfonylureas carry a notoriously high risk of hypoglycemia, while GLP-1 receptor agonists are great because they slow gastric emptying, help with weight loss, and actually lower ASCVD risk.
Now, what happens when that diabetic patient is admitted to the hospital acutely ill? The universal next best step is to just discontinue all their oral anti-diabetic drugs. The response is going to be way too unpredictable and the renal risks are just too high. Instead, you'll want to switch them over to a basal bolus insulin regimen. You'll dynamically adjust that bolus about 30 to 45 minutes before they eat based on their actual oral intake. Just remember, though, insulin obviously brings its own direct risk of hypoglycemia, so frequent point-of-care glucose monitoring is essential.
Okay, say your patient wakes up with morning hyperglycemia. You've got to figure out why. Is it the dawn phenomenon? That's just a normal physiological morning spike in growth hormone. If that's the case, your fix is simple. Give their long-acting insulin dose a bit later at night. But if it's the Somaji effect, which is actually a rebound spike caused by nocturnal hypoglycemia, the logic flips. For that, you actually need to reduce their evening dose of long-acting insulin. Let's look at SGLT2 inhibitors, like empagliflozin. These drugs work by blocking glucose reabsorption right in the proximal tubule. This causes glycosuria, which leads to weight loss, but more importantly, it profoundly slows the progression of diabetic kidney disease and provides massive heart failure benefits. But the exam loves to test the downsides, right? You absolutely have to watch out for volume depletion, genitourinary infections, and that really tricky diagnostic trap of euglycemic ketoacidosis.
Moving right along to Section 2, hypertension comorbidity logic, and how we tailor the treatment.
Looking at the JNC8 recommendations, there's a clear distinction to make. For patients 60 and older who don't have chronic kidney disease or diabetes, we don't initiate blood pressure meds until they hit 150/90. But if they do have CKD or diabetes, age doesn't matter. The target is immediately more aggressive, and we initiate treatment at 140/90. This is where comorbidities dictate your drug choice. Take a patient with gout. You have to avoid thiazide diuretics because they raise uric acid. Instead, reach for losartan since it actually helps excrete uric acid. If the patient has proteinuric chronic kidney disease, an ACE inhibitor or an ARB is mandatory for protecting the nephrons. Just make sure to monitor their creatinine and potassium closely, and remember, these are strictly off-limits in pregnancy and bilateral renal artery stenosis. What about a post-MI patient? They're going to need antiplatelet therapy alongside their blood pressure meds. For atrial fibrillation, you'll want beta blockers or non-dihydropyridine calcium channel blockers for rate control. And don't forget, those AFib patients often need anticoagulants. If you use warfarin, that means strict INR monitoring and knowing that serious bleeding requires IV vitamin K plus prothrombin complex concentrate. If you opt for DOACs instead, you've got to pay very close attention to their renal dosing. All right, Section 3, heart failure and diuretics, specifically managing volume and rhythms. When we treat volume overload with loop diuretics, we're definitely going to see some electrolyte shifts. Loops cause hypokalemia and volume depletion, but they also drop calcium levels, which ties into their risk of ototoxicity. Thiazides, on the other hand, also drop potassium and can cause hyponatremia and hyperglycemia, but they actually retain calcium. That distinction is a super high-yield way to differentiate causes of hypercalcemia versus hypocalcemia. And then there's spironolactone, an aldosterone antagonist we use heavily in heart failure. Just watch out because it can cause hyperkalemia and notoriously gynecomastia. If you're using antiarrhythmics, you need to understand use dependence.
This is essentially when a drug's pharmacological effect gets stronger as the patient's heart rate gets faster. For instance, Class 1C agents will show up as prolonged QRS durations at faster heart rates, while Class 4 calcium channel blockers will present with prolonged PR intervals. And while we heavily rely on beta blockers for heart failure and rate control, always remember they can severely worsen bradycardia, severe asthma, and myasthenia gravis. On to Section 4, statin therapy and myopathy for ASCVD prevention. The rules for statin intensity are pretty clear-cut. If you have a patient needing secondary prevention for established atherosclerotic disease, or literally anyone with an LDL of 190 or higher, you start them on high-intensity statins immediately. We're talking atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. For diabetic patients between the ages of 40 and 75, their specific 10-year ASCVD risk is what dictates whether you go with high or just moderate intensity therapy. Now, if a patient develops mild statin myalgia, the next best step is just to pause the medication and switch them to a different, usually moderate intensity statin. But, and this is a huge but, if they have severe skeletal muscle necrosis with a CPK over 1,000 units per liter, that is rhabdomyolysis. You have to permanently discontinue the drug. This risk shoots way up if there are interacting drugs, unrecognized hypothyroidism, underlying renal disease, heavy alcohol use, or if statins are combined with microtubular inhibitors like colchicine. Section 5. Osteoporosis and bone protection, focusing on minimizing fractures. Let's say you're looking at routine labs for an older adult, and you notice an isolated, completely asymptomatic, elevated alkaline phosphatase, but their calcium and phosphorus are totally normal. That points to a very specific etiology. But before you jump to treatment, you always need to evaluate baseline calcium, renal and hepatic markers, a CBC, and vitamin D levels, just to rule out any secondary causes. That specific lab pattern we just mentioned, it heavily suggests Paget disease of bone. It's driven by hyperactive osteoclasts, causing disorganized bone turnover, which you can actually see as a focal increase in uptake on a bone scan. The direct treatment here is anti-resorptive agents, specifically bisphosphonate. Speaking of bisphosphonates, they are our first-line anti-resorptives. To avoid esophagitis, patients absolutely must take them on an empty stomach with a full glass of water. They are completely contraindicated if the patient has renal impairment. Also, you need to discontinue them after about 5 years to prevent atypical fragility fractures, and definitely monitor for osteonecrosis of the jaw, especially if they are having dental work done. Now, if a patient has severe acute or cancer-related bone pain, they might actually need opioids. If so, prescribe the shortest effective course, mandate a strict bowel regimen, and constantly monitor for sedation, respiratory depression, constipation, and the risk of falls. We also have to talk about chronic glucocorticoids. These drugs drastically reduce bone formation, which skyrockets the risk of osteoporosis. That's on top of increasing the risk of infections, hyperglycemia, hypertension, mood changes, myopathy, and adrenal suppression. Always use the lowest effective dose for the shortest possible time. If you have a high-risk patient starting medium or high-dose steroids, you must proactively start them on oral bisphosphonates, along with standard calcium, vitamin D supplementation in a weight-bearing exercise routine. Finally, Section 6, high-yield drug toxicities, looking at lithium, lead, and beta blockers. Interestingly, chronic lithium toxicity usually isn't from an intentional overdose. It almost always stems from decreased renal clearance. Things like simple dehydration or starting the patient on NSAIDs, ACE inhibitors, or thiazide diuretics will cause lithium clearance to just plummet. And as a quick side note on NSAIDs, remember they can worsen renal function, exacerbate heart failure, trigger GI bleeds, and dangerously amplify anticoagulant bleeding risks. Anyway, back to lithium. When clearance drops, it causes lethargy, ataxia, and tremors, which can quickly escalate into full-blown seizures that might actually require hemodialysis. If you're screening an at-risk infant and a capillary test suggests lead poisoning, the definitive next best step is always to draw a venous sample to confirm it. If that venous level comes back at 45 micrograms per deciliter or higher, you initiate chelation therapy immediately. Recognizing these specific toxicities is also massive for transplant patients. For example, tacrolimus and cyclosporin are notorious for causing severe nephrotoxicity, hypertension, and neurotoxicity. On the flip side, azathioprine and mycophenolate are going to trigger profound bone marrow suppression and gastrointestinal toxicity. Let's wrap up with severe beta blocker overdoses. If a patient comes in with profound hypotension, severe bradycardia, and an AV block, your first-line treatment is going to be IV fluids and atropine. But if they don't respond to that,
Administer glucagon. Glucagon is amazing here because it completely bypasses the blocked beta receptor. It binds to its own separate receptor, directly increases intracellular CAMP, and restores the heart's contractility.